Right, can you guys see my screen? Everything good? Clear?
Yes.
Excellent.
Mhm.
Okay, very good. All right, welcome to week 5. Today we're going to discuss treatment of substance abuse. I know there's a lot of substances that could be abused, but we're going to keep it very specific just for now. And as I guess, as your career goes on, as you move up the program, we'll discuss a little bit more stuff in detail. We're going to focus a lot on alcohol use disorder today and a lot on opioid use disorder. And we're going to touch a little bit on amphetamines and marijuana use. All right. Once again, agonist spectrum, make sure you know this. Any questions with this? Anything that's not clear that I can explain? So we do have some agonist therapies and we have partial agonist therapies. Can someone give me an example of an agonist therapy in substance abuse? What's an agonist therapy? For opioids. Give me an example. Anyone? Methadone. All right. So methadone is a mu opioid agonist. Let me use that. It has a long half-life, and we usually switch people on that, right? It's better than heroin. Partial agonist, we also have something that's a mu opioid partial agonist, which we're going to talk about later. Anyone know what it's called? Starts with a B.
Suboxone, buprenorphine.
Very good. Buprenorphine, perfect, right? It's a partial agonist. And we have an antagonist. And what's a good example of an antagonist? You guys should all know this.
Naloxone.
Very good, right? Yeah, naloxone. And what's the long-acting version of naloxone called?
Naltrexone.
Very good, naltrexone. Excellent. Good, you guys did your reading. Very good. Pharmacokinetics and pharmacodynamics. Once again, understand the absorption, distribution, metabolism, excretion of the medications, CYP-drug interactions, of course, and pharmacodynamics. How does it work? For substance abuse, we're really going to focus on pharmacodynamics because that's how a lot of these medications are going to be working on specifically. There's not really many drug-drug interactions with the substance abuse medications, but if there is, we'll discuss that also. All right. This is a very important concept in substance abuse, all right? Upregulation and downregulation. So when someone is using a substance, what's going to happen to neurons? If you're using methamphetamines every day, what's going to happen to your dopamine neurons? Are they going to upregulate or downregulate? Too much stimulation.
Downregulate.
Very good, right? Too much stimulation. The neurons are going to protect themselves from excitotoxicity. They're going to downregulate or desensitize, all right? And obviously during withdrawal, it would be the opposite, all right? Okay, the malfunctioning brain circuits, we're going to touch on this a little bit, and I'll show you guys a picture later on. So it's believed that for impulsive behaviors, the circuit is still the CSTC circuit. Remember the CSTC circuit? We spoke about that a little bit during the anxiety. We're talking about the worry loop, right? So it's the cortex to the striatum, to the thalamus, and back to the cortex. So in particular, for impulsivity, we have the cortex, which is the anterior cingulate cortex, right? Or the ventral medial prefrontal cortex, which connects to the ventral striatum, and it goes right back to that same part of the brain, right? So it's a loop. Anterior cingulate cortex to the striatum, back to anterior cingulate cortex, and that goes on. If you do something impulsive long enough, it becomes compulsive, right? And it almost becomes automatic. So that usually stems from your orbital frontal cortex to your dorsal striatum, right, which is the motor pathway, back to the orbital frontal cortex. All right. Any questions with that? Once again, this is just parts of the brain to understand. All right. And anyone know where the anterior cingulate cortex is on this graph? It's not listed, but where would it be? Where is it? Can someone explain to me where it is? It rests on top of something important, right in the middle of your brain. It's resting on top of the corpus callosum, right? The corpus callosum is a part of your brain that connects the left and right hemispheres, all right? And the anterior cingulate cortex would actually be right on top. It's resting right on top of it, all right? Okay. I was trying to simplify it, but this is one of the diagrams I thought was most simple to explain. So it looks a little convoluted right now, but I'm going to try to explain it to you. So what you're looking right now is what part of the dopamine pathway is this called? Oh, it's actually listed on this, the mesolimbic pathway, right? Which is also implicated in what disorder?
Schizophrenia.
Very good, right? So it's the reward pathway. So whenever you see something, so we like to use the term salience. So salience means that something catches your attention, right? Sometimes we try to characterize schizophrenia as a hypersalient state, and that's why people are very psychotic. So hypersalient state means that you're putting meaning to things that might not have any meaning. So someone who has schizophrenia might look outside their window one morning and see a black unmarked car and say, oh my God, this must be the FBI, right? And then they all of a sudden they link that to not paying their taxes on time that year. And they say, oh my God, the FBI is out to get me because I didn't pay my taxes. You know, And then all of a sudden one thing leads to another. All right. So they're kind of like making a story because everything is salient. They can't like block out things that are not important. So when it gets to the very extreme state, right, it also can cause addiction. So sometimes someone takes, I don't know, Adderall from a friend, and it's a higher dose than usual, and gets a euphoric effect. And all of a sudden starts craving it and uses it again and again and again. And what happens to that dopamine neuron? That nucleus accumbens is gonna what? It's gonna downregulate, right? Too much stimulation. And eventually they're gonna get into what? What happens when someone uses stimulants for such a long time? What do they start experiencing? Not withdrawal. I'm talking about when you use it for a long time. You actually become anhedonic. Because what happens is all of that stimulation is gonna, even though your neurons are gonna try to compensate, eventually they get into a state in which those dopamine neurons actually die out. Once they die out, it's kind of, some people call it burnout, and patients kind of just still like always depressed. And they go to the hospital, they go in and out, they get put on medications, and it doesn't respond to anything. Right. So it's kind of like too much use of amphetamines or stimulants can also cause burnout. All right. So the common pathway, yes, is the mesolimbic pathway. So that's the common pathway in which causes reinforcement and addiction. But there's connections to the VTA from other neurons as well, right? So you have the glutamate input right there, which is actually innervated by nicotine. So you smoke a cigarette, and what happens to glutamate? You innervate glutamate, and if glutamate innervates dopamine, the VTA, what's going to happen? The VTA is going to do what? Increase
dopamine.
Very good, right? Now there's also a GABAergic interneuron. So a lot of this stuff makes sense later on when you start thinking about interneurons. So for instance, if I say something is a 5-HT2A antagonist and it increases dopamine in the nigrostriatal area, that 5-HT2A neuron is actually on a receptor, is actually on a GABAergic interneuron. So when you stimulate it, right, it's going to tell the GABAergic neuron to actually stop, or it might increase, depending if the GABAergic interneuron is connected to a glutamate. So you do have connections in the brain in which GABA is connected to glutamate and then connected to the neuron, or the opposite. Glutamate's connected to GABA, it goes to the neuron, right? So it's almost like, I don't know, electricity in a way, right? The way the circuits are built. You have to understand what's positive, what's negative. You just follow the circuit. That'll tell you. So if something is positive, but it's hitting something that's negative, what's going to go to the next neuron? The next neuron is actually going to stop secretion, right? Because they could be positive, negative, positive, but it's a net effect that you're going to see later on down the road. So that's why sometimes it's very hard unless you visualize it. And if I told you, I don't know, 5-HT2A antagonism increases dopamine, and you say how? Well, if I showed you a picture of a GABA interneuron in the nigrostriatal area, it'll make sense, right? Because GABA is inhibiting, or if GABA is connected to a glutamate, it's going to inhibit excitation and then do what? Inhibit.
Decrease.
Right? It gets a little, it gets confusing, but you have to visualize it. I'm just giving you an example. So if you look at the GABAergic interneuron, it gets innervated by cannabinoids, right, which can be marijuana, ethanol, alcohol, and opiates. So alcohol actually also binds at mu-opioid receptors. So if you look at the dopaminergic VTA neuron here, there's also mu-opioid receptors there, that if you drink alcohol, not only is alcohol working GABA receptors, but what happens if it hits a mu-opioid receptor on the dopamine neuron, it's actually going to secrete dopamine. All right, so you're getting, that's the euphoric effect from alcohol. So it's a mu-opioid receptor on a VTA neuron that's going to cause dopamine to be released. And when it hits the nucleus accumbens, it's going to cause reinforcement, right? Or pleasure or euphoria. Does that make sense? How does cocaine work? Anyone know? What does cocaine do?
It's a mu-opioid receptor as well?
No. Cocaine actually, so what cocaine does, it actually works on the pumps also. So it increases the amount of dopamine in the pump. All right. Okay. This is how alcohol works. Once again, same concept, right? So you on the very left, you have a dopamine neuron, and it doesn't show nucleus accumbens, but nucleus accumbens is actually going to be in the very top. So just assume that the VTA is connected to nucleus accumbens going up. But look, you have three projections there. You have a GABA interneuron, which is in the other picture. You have an arcuate nucleus, which is actually where opioid receptors come out. So that's where B endorphins come out. So normally, when you get that high, when you're running and you feel good, or you're working out and you get that pump and you feel good, that's the arcuate nucleus secreting endorphins, right? And that's going to hit the receptors in your VTA, and that's going to cause the euphoric effect, right? And there's also, I would say, glutamate neuron in the prefrontal cortex. So if you look at the arcuate nucleus, right? If someone takes alcohol is actually going to bind to dopamine neuron, like I said, the mu-opioid receptor, but it's going to do two things. So alcohol actually also causes increased glutamate release, and it also works in the GABA interneuron. So alcohol has many different receptors that it touches, but it does many different things, right? Alcohol sometimes could be a depressant. It could be a stimulant. right? It can also has some analgesia effects also, and it's also an antidepressant in some doses. So that kind of explains all the different receptors that it touches and all the different neurons. It'll cause all those different effects. All right. I don't expect you to memorize all of this. I just want you to understand the concept. There's many different connections, and depending on what receptor is attached to it, there might be a different effect. Is that clear? So these are the different opioid receptors. You have mu, delta, and kappa. All right. So mu usually is for sedation, euphoria, tolerance dependence. A lot of that's implicated with the mu receptor. Delta is similar also, but look at that. It's interesting. Delta also has to do with, it also has an antidepressant property also. All right. So actually, that's why when you take opioids, people do feel a little better, right? They get euphoria and they say, well, my depression is a little bit better, right? But what are the risks of that, taking that long term? And you have kappa. So there's new antidepressants that are actually being developed now. They have something called S-methadone, which is an isomer of methadone, which is actually a kappa antagonist. So if you block kappa, so look at that, kappa agonist, right? So kappa agonist can cause dysphoria, make you feel, not feel so well. So if you block that receptor, it can do the opposite. So there's actually research going on to now, and it's showing some positive trials that kappa antagonism can also work for depression. All right. So the newer meds that we're developing now are NMDA antagonists to help with depression and modulation of opioid receptors for depression. All right. That's on top of the other antidepressant medicines that are coming out also, or like ketamine and TMS, all the other stuff. CAOS. Okay. I know if you work inpatient, you probably know this already, but what CAOS is for opioid withdrawal. All right. So depending on, what their score is, would determine how much Suboxone you give them. All right. So again, if you look at the scale, it also gives you like what the symptoms are of opioid withdrawal. All right. So obviously when someone's withdrawing, their pulse might go up, right? If someone's withdrawing, they might have diarrhea, right? If someone's withdrawing, they might have, dilation of the pupils. So that would be the total opposite of opioid intoxication, right? So you choose, either you memorize withdrawal and you just kind of put it together and say, okay, if this is withdrawal, intoxication would be the opposite. Or you memorize intoxication and then withdrawal would be the opposite. Does that make sense? Okay. These are the medications that we use for opioids, all right? So we use methadone. So like I mentioned before, methadone is also mu opioid agonist. But why is it better to put someone on methadone?
It's a full mu opioid agonist.
But why put them on methadone if they're using heroin or something else? Why switch to methadone? What's safer about it?
Long acting.
Very good, right? It's long acting and it's controlled and it's given in a controlled setting. Okay. What about buprenorphine? What is the advantage of using buprenorphine?
It's like a partial.
Mm-hmm. But what's special about it compared to a full agonist? Why would I put it on a partial agonist?
It has the naloxone as well. Oh, and
that would be Suboxone. Yeah, so Suboxone has naloxone in there. But what's the advantage of giving buprenorphine by itself, partial agonist?
Doesn't it have a long half-life?
Compared to what?
Compared to methadone?
No, methadone has the longest half-life.
How longest?
It has a ceiling effect. So the thing about a partial agonist like buprenorphine is that they can take a lot of it, but it maxes out. So they're not going to get the same high as if they, abusing methadone. You can abuse methadone also, or if they take, another opioid off the street, right? It has a ceiling effect. Buprenorphine naloxone, also called Suboxone, what's the advantage of that formulation? What's the advantage?
If they try to abuse it, it won't work because of the naloxone.
Yes, excellent, right? So the naloxone only kicks in if they try to use it any other way. So if they try to like inject it or they try to use it without going through oral route, it's not going to work. There's another medication that works that way also in psychiatry. Which medicine? If you try to abuse it, it doesn't work. We talked about it in ADHD. Starts with a V. Vyvanse, lisdexamfetamine, remember? So lisdexamfetamine is formulated in a way in which if you try to use it any other way, it's a prodrug. So it has lysine on top, and lysine has to be cleaved off when you take it orally. If that lysine is there, it activates, it doesn't work. So if someone tries to sniff it, or someone tries to inject it, lisdexamfetamine doesn't work. That's the reason why they made it. It's a medication that's safer for patients who have substance use disorder and try to abuse it, all right? Lofexidine is what? What class medication is it? What is lofexidine? It's
Is it
similar to
alpha?
something.
Is it alpha 2 agonist?
Very good. So it's very similar to clonidine. But what's the advantage of lofexidine? Why not just give someone clonidine? We still use clonidine. What's the advantage of lofexidine?
Does it not do anything to the blood pressure like clonidine does?
Yes, it doesn't cause drastic drop in blood pressure the same way that could happen with clonidine. It can a little bit, but it's much safer. So that's the reason why we use it more. All right. It's a fairly new drug. It's only been out, I think it came out 2018. It's been used in Europe a lot longer, but it was FDA approved here in 2018. So it's a new med, but it's much safer than clonidine. All right. And obviously everyone knows naloxone, Narcan, all right, works rapidly. The problem is if the half-life of the opioid is longer than the Narcan or the naloxone, the person can go right back into intoxication. All right. Any questions? Okay. Once again, difference between naltrexone and naloxone. How I remember it is Trek. Trek is like longer, right? If you go on a Trek, it's longer. So naltrexone is a longer half-life, lasts longer. And you have the injection, which is Vivitrol, which you can give, you know, once a month. And you have naloxone, which is a rescue drug. All right. Naltrexone is used for other disorders also, off-label. Anyone know? Has anyone ever seen naltrexone used for anything else besides opioids?
Alcohol.
Okay, very good. Alcohol, yes, alcohol use. Because remember, like I said, alcohol binds to mu opioid receptors. So if you have an opioid antagonist, the alcohol is not going to cause the euphoric effect, right? What other? Use naltrexone for other things also. Take a guess. What causes pleasure that you want to stop?
Self-harm.
I'm sorry?
Self-harm. When people
Yeah,
cut,
self-harm, yeah,
then
very good.
naltrexone take away the pleasure of it.
Yes, excellent. Yes, I use that actually in pediatric clients who self-pick or harm themselves. So I use naltrexone PO 50 milligrams. All right. It's important before you use these medications that you do a liver enzyme test first, right? Do a liver panel. Make sure that ALT, AST is okay. Signs and symptoms of opioid intoxication. Once again, you know, you should know this. What you see is what you get. So memorize one, memorize intoxication so that you know withdrawal will just be the opposite, okay? Or whatever's easier for you. This is MRI of patients who are chronic alcoholics. So if you look here, you can definitely see a lot of degeneration. So those are the ventricles. So the ventricles are enlarged. So when the ventricles are enlarged, you assume that brain matters less, right? What other illnesses do we see in large ventricles? Besides
dementia.
Dementia also? What about psychiatric though?
Schizophrenia.
Very good. Schizophrenia, right? In large ventricles. Wernicke's encephalopathy. All right, we're moving into alcohol now. So what is has anyone ever seen a patient with Wernicke's encephalopathy? I'm just curious. Anyone work a patient and ever treat a patient with that? Anyone?
Yes, I used to work in a detox.
Oh, excellent. Okay, so can you give us like what you saw and, you know, how the patients presented and how you treated them?
He was very bizarre. Like he came in, he wasn't so bizarre, but then he also came in for detox. Like he was starting to stick sandwiches in his ear. He would just say very bizarre. They were starting to treat him for psych, and then they realized that he had Wernicke.
What happens if Wernicke isn't treated? What does it lead to?
Didn't it lead to coma?
Cortical psychosis. All right, so that's irreversible. So Wernicke is reversible if you get to it on time. Why is thiamine so important though? That's important. So before you give someone dextrose or glucose, you have to give them thiamine first. Why? What'll happen? Why do we need thiamine? What does thiamine do in the body? You guys should know that. Anyone want to take a guess?
Does it help with like the myelination and just like transmission of action potentials?
So more particular metabolism, energy metabolism. All right. So what happens if you don't have enough thiamine and you give someone dextrose, you need energy to break that dextrose down. But if you don't have thiamine, you don't have ATP, right? So you're going to overwork your neurons and it's going to cause damage and it's going to kill off your neurons. So before you give someone glucose, because giving someone glucose and has thiamine deficiency, the body's trying to make energy, but they don't have thiamine there to make the energy that it's going to cause it to go into overdrive and it's going to cause worsening, right? Brain damage. So make sure you give someone thiamine, right? Usually we give thiamine 100 milligrams TID, you know, and we supplement it, okay? So this is a triad. So normally, like, you know, what was said before, patients might be confused. They might seems like psychotic, right? Oculomotor, you might do a lateral gaze test and you'll see lateral nystagmus, so dancing of the eyes. You might also see ophthalmoplegia. Well, the eyes will not move. Like one eye will move and another eye won't move. I've seen that before. And obviously cerebellar dysfunction, they might lose their balance and they might fall down very easily, okay? So the risk factors are obviously chronic alcoholism, someone who has bariatric surgery, anorexia nervosa, obviously, okay? Questions so far? No. CIWA, back to alcohol, all right? You know, believe it or not, a lot of people forget that alcohol is the most dangerous. You're not going to die from opioid withdrawal. It's going to suck, but you're not going to die from it. But you are going to die from alcohol withdrawal. Why? What does it lead to?
DT.
DT, right? And what does DT mean? Doesn't mean Donald Trump, right? What does it mean? Delirium tremens, okay? So it's very dangerous. You want to make sure. So usually with alcohol withdrawal, what do? What do we give someone? What is a synthetic version of alcohol? So you have to kind of, you know, taper someone off safely, right? What do we use?
Benzos.
Ativan. Yes,
we use Ativan, we use Librium, okay? Sometimes people use barbiturates also. It's interesting. There's a group of psychiatrists, addictionologists actually, that don't use benzos. Have you heard about that? They use anticonvulsants to wean people off. I don't know. People who work in detox. Have you ever seen that? I've never seen it, but I've heard about it. Anyone ever seen that technique work? No benzos to wean someone off safely? Has anyone seen that? Jessica, I think that was you, right? You worked in detox before?
Yeah, but I didn't hear the first part of the question. I know, like with impaired liver, we used to give CRX, but I didn't hear the first part of what you said.
Yeah, they use anticonvulsants. So they use topiramate, they use Depakote, they use Keppra. And the belief is that these addictionologists or psychiatrists that specialize in addiction medicine, they're saying, well, why would I want to use something that's toxic, like, you know, like benzos, in which someone could be addicted to benzos also. So they're like, you know, let's just control them in a controlled environment. Because what's the danger of alcohol withdrawal? Seizures, right? So if you give someone an anti-seizure medication, I mean, I've never firsthand done it, but I've read about it. It sounds very interesting. I guess in a controlled environment, you can do that in like a hospital if you really make sure. And you can load Depakote. So they would load an anticonvulsant medication, manage that, make sure the patient can't have obviously a seizure, and obviously treat the autonomic hypersensitivity, the arousal with alpha-2 agonist, right? It's interesting. I mean, a lot of people don't use it, but there are people that do it. So they use anticonvulsants instead, and they don't use benzos. All right, but you would have to do a CIWA anyway, just to see how someone's responding. Any questions? Once again, these are the medications we use for alcohol use disorder. So, Jessica, what did you see a lot? Did you see any of these used a lot? Were they using a lot of acamprosate or disulfiram?
We used to use a acamprosate that was a real lot, but it was about 10 years ago.
Mm-hmm.
And not so much anymore.
Okay, why is that? I'm just curious.
I don't know. Like we have a new medical director of the detox, and he kind of switched everything around. So what does he use? I'm just curious. Withdrawal. He's using naltrexone, but I haven't seen like Campril used. That we had like a lot of success with. That's why I'm not sure why they not using it.
Okay, interesting. All right. Disulfiram. Do you still see that used a lot or no? Jessica?
No.
Right. Yeah. There is something you should know about disulfiram though. Disulfiram has an interaction with people who have schizophrenia or a family history of schizophrenia. It can actually cause psychosis. Have you ever heard about that before?
No.
Okay. Norepinephrine.
I think because we work for Northwell, so we have to follow Northwell protocol. Like a lot of times, sometimes we'll do stuff and it just doesn't seem to make any sense.
Okay. So why does disulfiram cause psychosis? Anyone know? How does disulfiram cause psychosis? What does it do, first of all?
Is it the acetaldehyde buildup?
Okay, for alcohol, yes, but it also works on dopamine somehow. What do you think? All right, so there's an enzyme called dopamine beta hydroxylase, all right? And that's an enzyme that converts dopamine to epinephrine. So if you inhibit that enzyme, right, dopamine is not turning to epinephrine, what's going to happen? You're going to have a buildup of dopamine. So if someone has a family history of psychosis or is predisposed to that or has schizophrenia and you give them disulfiram, they're going to have an overabundance of dopamine, which is going to cause, if that dopamine increases in the mesolimbic area, it can cause psychosis. So if you are going to give someone disulfiram or antabuse, make sure you ask them about any past history of psychosis or any family history of psychosis. All right, that's important. So it's called disulfiram-induced psychosis. I've seen it a few times in the hospital. What is this? If you work in child psych like I do, I see kids also, this is big. Kids will inhale and sniff anything. Okay, it's called toluene. All right, so they sniff it, they get high. People use nitric oxide also. People will sniff anything, but just make sure you screen for this. All right, ask them. Because if they're psychotic or having mood symptoms, and it's because of this, you would tell the parents to make sure you lock all of these things up so the kids don't get to it. All right. All right, meth users, look at this. So this is a PET scan of dopamine receptors. So the red is actually dopamine receptors. So someone's healthy, you see dopamine receptors right there. There's some red. Someone uses methamphetamine for a month. Look, there's barely any, right? Why is that? Because it's what? Down-regulating, all right? Because it's trying to protect itself from excitotoxicity. That's the mesolimbic area, by the way. All right, so what happens? Someone's abstinent for 14 months and everything slowly comes back. That's a long time, though. Can someone stay sober for a year? We hope so, but it takes time. But, that shows how fast the brain sometimes can adapt to, in 1 month, those dopamine receptors are going to downregulate and desensitize. Cannabis. I get a lot of questions about this. All right. I assume that everyone uses cannabis nowadays. So the reason why I wrote that in the bottom, so cannabis is an inhibitor. It inhibits 3A4, 2C9, 2C19. That's significant in psychiatry because a lot of our meds are 3A4, 2C9, 2C19. Specifically 3A4. A lot of the atypical antipsychotics are 3A4, the newer ones, like Vraylar, Caplyta 3A4, Latuda 3A4. 2C9 is Depakote, 2C19 is Lexapro, Celexa, and Sertraline. All right, I know this is what you guys wanted to know for the final. I know you guys have a lot of anxiety about this, but I'm not going to test you a lot of like specific. I'm not going to ask you about like xylazine, that new drug that everyone's abusing. All right, that's new. But I want you to understand how people can become addicted through the mesolimbic pathway. All right, just understand upregulation, downregulation, tolerance, withdrawal. Understand what happens if a receptor is being innervated a lot. What does too much dopamine do? Right, we know that causes psychosis. Like PCP intoxication causes psychosis. Right. Know what happens when you're withdrawing from opioids. What happens when you're intoxicated? Basic brain chemistry, right? With drugs of abuse, just understand, again, that's the mesolimbic area. Understands, cravings, how do we manage it? Naltrexone, long-term, naloxone, short-term. All right. All right. So I'm actually going to stop recording now because I want people to attend this. So if anyone who didn't attend this, too bad for them. They're not going to get the extra material. I'm giving you, because you guys actually took the time to spend your Friday night with me. I'm going to stop this recording.